Hi guys, Rapid Ophthalmology here. So today you're studying Orbital Pathology with me, Dr. Abid Nawaz. So starting with Thyroid Eye Disease. This is the most common cause of bilateral and unilateral proptosis in adults. This is associated with thyrotoxicosis, which is also known as Graves' disease, where an increase in thyroid hormones happens due to an autoimmune condition which causes an increase in IgG antibodies. You should always check a person's TSH when he has a thyroid eye disease, even if it's an ophthalmology case, to rule it out. This is normally seen in females 40 plus, and it has all the typical hyperthyroid features. Risk factors for a post-Graves disease, for him to have a TED or a thyroid eye disease, smoking has the highest risk factor. The pathogenesis of the ophthalmopathy in thyroid eye disease would be antibodies against thyroid gland, cause damage to the eye and adnexa also. So you have antibodies that are acting against the thyroid gland, but these antibodies, even though they affect the thyroid glands, they also tend to act against the person's eye and the adnexa. So this will have a TED, which might eventually cause a muscle fibrosis and a restrictive myopathy. So the person is essentially not able to move his eyes very freely. There is some movement, but there is a little bit of restriction. So then we have, in clinical features, there is a congestive stage and then there is a fibrotic stage. A congestive stage is the initial stage of TED, which lasts for around 3 years, whereas a fibrotic stage is a painless stage in which the eye becomes white, and then there is, which means the sclera is not very red. There is not much congestion in the conjunctiva, but there is a motility defect in the fibrotic stage. In the soft tissue involvement stage, you see that there is a PLPRD, which are the general symptoms for ophthalmology, which is P for pain, L for lacrimation, P for photophobia, R for redness, and D for discharge. Then we have Bulbar Hyperemia. Bulbar Hyperemia is a very interesting thing that is seen. So if this is the eye and this is the lateral part of the eye, so from the lateral rectus, this part gets, there is a lot of congestion in the lateral part of the eye, and this diagram shows that congestion very clearly, and this is because of the inflammation involving the lateral rectus, and this is specifically seen in a thyroid eye disease, which is a pathognomonic feature for it. Then there is a periorbital swelling also seen, which has edema near the orbital septum, and there is fatty prolapse into the eyelids, because of which there is periorbital swelling. Then there is some corneal superior limbic keratitis involvement also. So this is the periorbital edema. So this would be the bulbar hyperemia. You can see there are vessels that are congested. All these vessels are congested in the conjunctiva, and then you have periorbital edema. This is the area where we can see the periorbital edema. There can be some fatty prolapse also, and you can see there is severe congestion, and also there seems to be corneal involvement. So this is a typical presentation of soft tissue involvement in thyroid eye disease. Then let's go towards lid retraction. Lid retraction, 50% will have a scleral show. This scleral show is a very interesting thing, because this happens because there is a humoral overaction of the Muller's muscle. So the Muller's muscle is a muscle that is basically responsible for, one of the muscles that is responsible for retracting of the eyelids. And if you have a sympathetic innervation, which generally is seen in patients with hyperthyroid habitus, they tend to have an overaction of the Muller's muscle, which causes the scleral show. Then you have a lid lag in a primary gaze, which is called as a Dalrymple sign. Then you have a scary gaze. You look at the patient and he has a very wide-eyed gaze, and it generally looks a little bit scary. So this is known as the Kocher's gaze. Then there is a lid lag on down gaze. So when the person is looking down, the lid is pulled up. So this is known as the von Greffe sign. So these are some of the cardinal signs that are generally associated with thyroid eye disease in ophthalmology. Then restrictive myopathy is seen in 30% of people, and definitely you will have a double vision. Then you basically have a defect in all the elevation, abduction, depression and adduction directions. This is all because of fibrotic contracture. Then you have an optic neuropathy, because whenever you're speaking about a compressive sort of a compartmentalization sort of a pressure, then you always have to look for optic neuropathy. This is seen in 60% of patients due to the compression of optic nerve. Central vision is impaired, obviously. Then you can also have a color desaturation, but these are not so prominent. Then central defects. If it's a central defect with an elevated IOP, sometimes due to an increased compression, may look like a primary open-angle glaucoma, but you have to rule out thyroid eye disease before actually diagnosing it as a primary open-angle glaucoma. The disc can be swollen or atrophic. Some extra points to be noted here are the histopathologic features evident in extraocular muscles specimen from patients with Graves' ophthalmopathy also may be seen in the lacrimal glands. So the lacrimal glands will have a similar histopathologic changes as you see in Graves' ophthalmopathy with other extraocular muscles. Then fibrosis tends to be less severe in thyroid eye disease, leading to partial loss of the normal glandular tissue. So now let's swiftly move on. So what are some of the investigations that can be done in a thyroid eye disease? They mostly consist of blood tests. So visual field testing would also be if you have an optic nerve involved, if you see there's a central vision defect, there's a color desaturation, there is a compression optic neuropathy. If these things are suspected, to rule them out, you do a visual field testing. Then MRI, CT and UHG are only good to see any muscle enlargements in TED and for an optic nerve compression. So there's a point about CT scan that I've written here. I must have come across this point and I felt this was interesting enough to include it here. Even though this is not a point specifically for TED, this is just a point about CT scan, but let's just have a look at it. CT scans represents a considerable improvement over first generation scanners whose resolution used to be 5 cubic millimeters. I think now they almost have like 40 cubic millimeters if I'm not wrong. So the treatment for a thyroid eye disease would first primarily will start with the cessation of stopping. Your patient has to stop smoking. Then according to the UGOGO, this is the body that decides classification for TED. It goes something along the lines of European, I don't remember the full form for GOGO, but that's not really important. I just felt the name was interesting, so I wrote it down. So then for mild disease, you can definitely go for lubricants for a corneal exposure, then NSAIDs to control with the inflammation, then head elevation might help out with the periorbital edema if it really hinders with the patient's vision. Then eyelid taping. Eyelid taping is generally done because the patient is not able to close his eyes properly. So when you physically close his eyes with the tape, what it does is it basically covers the patient's eyes overnight, and there is not going to be any evaporation, and the patient has gone good enough moisturization of the corneal surface and the conjunctival surface, and that might help him and prevent any development of ulcers. Then if it's a moderate to severe active disease, according to UGOGO, you can go for immunosuppressives, but you have to have at least 3 points out of these 7 for you to start with immunosuppressives. So this is a very interesting thing. You can't just start with immunosuppressives as it is. You need to have at least 3 out of 7 out of these points. So let's have a look what these are. This is spontaneous orbital pain, gaze evoked orbital pain, eyelid swelling considered to be due to be the active inflammatory phase. Then we have of TED. Then there needs to be eyelid erythema, redness of the eyelids, and then conjunctival redness considered due to active inflammatory phase of TED, chemosis, and inflammation of caruncle and plica. So one interesting thing that we can have a look at is all the underlying all the points of an underlying inflammation, which is the driving factor for you to start with immunosuppressives. If there is no inflammation, you've already passed the congestive stage and now you're in the sort of the chronic stage of TED, which really doesn't do a lot if you start with immunosuppressives. But if there is an early inflammatory stage, then it makes some sense for you to go with a immunosuppressive regimen. Then this is a very important thing to look at. So now that you've decided that the patient has 3 out of 7 points according to you, go and he can be started with a immunosuppressive. So let's look at how does the systemic steroid mainstay look like. So you start with the oral prednisolone 1 mg per kg per day. It is then tapered. Then you have IVMP, which is generally used if the patient is undergoing optic nerve compression. Just remember, if the patient is undergoing optic nerve compression, you have to go with IVMP. There's no other way around it. That would be the biggest indication for immunosuppression for steroids actually, if the patient is having an optic nerve compression, because you need to save the patient's vision at all cost. Then you go for 0.5 grams weekly for 6 weeks, or which can be decreased to 0.25 grams for a week, which has better outcomes and tolerance. So this was about systemic steroids. Then a combined radiotherapy along with azathioprine and low dose pred could also help. When I say pred, I mean prednisolone. So for optic neuropathy, this is a regimen for optic neuropathy. If patient is undergoing optic neuropathy, you can go for an IVMP. IVMP meaning an intravenous methylprednisolone, 1 gram for 3 days orally. Then IVMP 1 gram 6 times a day, alternate days orally. This can be done along with performing liver function tests to assess the functional capacity of the liver, to just find out whether you're not damaging the liver in any way. And some post-inflammatory complications would be, you're not supposed to do any lid surgeries until the treatment is complete, because it doesn't make any sense for you to do any lid surgeries, because you don't know exactly to what extent can the lid exactly be the lid lag or lid complications can be controlled just with medications alone. And once you've reached the maximum extent of correction, then you can go for lid surgery. Proptosis, if functional and aesthetic, just leave it alone. So if you don't have any aesthetic, if the patient does not have any aesthetic problem, even more so if the patient doesn't have any functional problem, and if there is a slight aesthetic problem, or if it doesn't have any functional or an aesthetic problem, then just leave it alone. Don't go for any surgeries. Don't just poke your eye into what nature has done very well. Then surgical decompression can be done along with an orbital fat removal. So there are a few approaches through which you can actually go for a surgical decompression and a orbital fat removal. Now there are basically 4 techniques. The first one being the one wall technique, where the deep lateral wall is basically you approach the orbital fat through the deep lateral wall. Then you have the 2 wall technique, which involves the medial and the lateral wall. Then there is a 3 wall technique, where you go through the medial, lateral and the floor, but this may cause a hypoglobus. Hypoglobus is basically when the eye goes down and the other eye is basically on the normal eye level. So since you are breaching the floor, this could cause the eye to go downwards, and this would also cause an infra-orbital nerve damage. So the 3 wall technique has some complications associated with it. Then the 4 wall is only to be done if it's a very severe orbital, if it's a very severe complication and you have to do the orbital fat removal. In this, even the roof is removed, obviously. So some other points that are associated with thyroid optic neuropathy would be, thyroid optic neuropathy is considered to be a compressive optic neuropathy because of the enlargement of the extraocular muscles at the orbital apex. So there is an enlargement of the extraocular muscles due to fibrotic contracture, and that is the one that is causing the pressure on the optic nerve. Treatment of thyroid optic neuropathy may include orbital radiation, 1500 to 2500 rad over a 10-day period, and orbital decompression, as we studied before, which provides the most potential for decompression of the optic nerve. So orbital decompression is very useful. Systemic corticosteroids are thought to be effective only in the acute congestive phase, as I told you. It's only in the early inflammatory phase that immunosuppression actually makes sense. You can't give immunosuppression many-lily and just expect some magical thing to happen. It works best. It has the most potential in the early phase, which is the congestive inflammatory phase of the, and in the fibrotic period it doesn't have much use. Therefore, if no response is noted within 3 weeks with systemic steroids, they should be tapered and another modality should be considered. Although a subtotal thyroidectomy may provide primary treatment of this thyroid state, it will have no effect on the eye findings, except perhaps late retraction. So late retraction might better itself, but apart from that, if you do not have any improvement in the patient's condition for 3 weeks, then just taper the steroids. The steroids are not working, and then a subtotal thyroidectomy may help. So now let's have a look at restrictive myopathy and a few things about it. So surgery is only done if the vision is compromised, or if the patient experiences a diplopia, and only when an inflammatory stage has been stable for 6 months, because you know that inflammatory stages are very notorious to spontaneously resolve, or they really react well and respond well to steroids. So you do not perform a lid surgery or a restrictive myopathy treatment in a surgical approach during the inflammatory phase. You wait for 6 months for it to stabilize, then you can think about a surgical modality. Till then, use prisms to correct the patient's diplopia and his alignment. Then the goal for treatment and surgery has to be binocular single vision. Recession of the inferior and the middle recti is commonly done with adjustable sutures. So you perform an inferior and middle recti recession, and for lid retraction, maybe you can go for a Botox injection to the molar muscle. So many of these were some aesthetic improvements, aesthetic treatments, but you generally go for a functional treatment before. So that was a short summary and about thyroid eye disease. I'm not expecting you to completely get thyroid eye disease if you listen to it for the first time, but this is sort of meant to be like a revision series, where this is the kind of video I would have wanted when I wanted to revise some of the stuff that I've read. So I hope this is beneficial. So guys, that was the video. I hope you guys liked it. The stamp for this week is the Chilean Conference stamp, and this is the globe within the human eye. As you know, I love ophthalmology stamps. You will see a new ophthalmology stamp every video, at the start and at the end of the video. Also, I'll be uploading my Patreon account pretty soon. You can subscribe to that, and if you like my content, please share and subscribe. Please stay home, take care, and stay safe.